Okay, I think I'm just gonna get started. I know we have low attendance today, but so one-liner for this patient, a 70-year-old woman with significant past medical history of tobacco use disorder, rheumatoid arthritis, Sjogren's. She's on a TNF inhibitor, a monoclonal antibody. She's got emphysema by imaging, significant smoking history, prior DVT and peripheral artery disease on rivaroxaban with a popliteal bypass, chronic pain. So she presents with fever, weakness, and a cough for the past 4 days. So based off that, what kind of history do you want to know? Differentials and test workup. I thought I'd start by the intern class. So someone comes in with fever, cough, and weakness for the past 4 days. What do you want to know? Sputum, just like a dry cough. Sick contacts, no. Her husband's been fine, just her getting sick. No recent travel. What else? Smoking history, 50 years, a pack a day, still smoking. No rehab facilities. She hasn't been hospitalized prior, and no recent swimming. So no treatment for emphysema or COPD, but because of her history, she's never had pulmonary function testing. So we are presuming COPD without any treatment. So the RA, she's on this new monoclonal antibody that she started. It's a 6-week infusion, and it's really helped with her RA. So she started that 2 months ago. With the infusion? No ILD. I could look up in the record, it's a monoclonal antibody, a new one, and it's a TNF inhibitor. Yes. I'm in, yeah. Okay. No IV drug use, but just smoking. Yeah, that's the only substance. No marijuana. She's Caucasian. She lives on a farm. Yeah, with her husband on many acres of land. She works on the farm. I think some Norco as needed, but really doesn't use it much, mostly Tylenol. No. And once she started the monoclonal antibody, she like really didn't need the Norco. She had a DVT that like maybe 6 months ago, and that required bypass. Unprovoked, and she's on rivaroxaban for it. And the smoking, like that. No weight loss, no night sweats, just like super fatigued, and then fever the past few days. And yeah, acute for like 4 days of fever, weakness, and cough. She has PAD, and then she had a DVT as well. Yeah. 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 Yes. Yeah. No edema. She's a really thin woman. And yeah, very thin, no edema, no orthopnea. No recent travels, no sick contacts. Her husband's doing fine, and they've been hanging out together. No, no pains. Dry. All right, so maybe write some of this one-liner up there if you're able. So we got fever, weakness, cough, rheumatoid arthritis, Sjogren's on a monoclonal antibody TNF inhibitor, presumed COPD/emphysema, never tested, PAD, DVT on anticoagulation. Okay. Yeah, so she has some chickens, she has some cattle, and she has lots of birds. She has like a lot of pets, birds, and she will go to different aviaries to volunteer with the birds. I don't know. I mean, it's a weird. Her husband hates the birds too, trying to get rid of them. Oh, I don't know, let's see, chat. When was her last infusion? Her last infusion was like 4 weeks ago, and it's an every 6-week infusion. Okay, so with fever, cough, and sort of weakness for the past 4 days, what are we thinking possible diagnoses? Upper respiratory infection, pneumonia. Do you want to write some differentials up on the board there? TB. Yeah, yeah. So pneumonia, we have viral versus bacterial, okay. Great, okay, so for these symptoms, fever, cough, and the weakness and our potentials here, what do you want to order? I want to start with the interns. Hey. CBC, okay. What else? Chest x-ray for sure, okay. COVID, you can do RPP, yeah, okay. What else? Put in your orders for admission. BMP. Let's do both. Okay. No BNP. Okay. All right. Yeah, so ProCal, okay. What was that? Okay, okay. Yeah. Okay, so fever, blood cultures, because essentially we're, she's, so physical exam, we said she was like cachectic, she's a fever, she's tachypnic, she is requiring like 5 liters nasal cannula, so acute hypoxic respiratory failure. Her lungs are really diminished on the left, clear on the right, and just really wasted, very thin, but no edema whatsoever, no rashes. Okay. No tripoding. No, just kind of laying there in bed. She can talk. She'll desats when she talks. Okay, good. Any other tests? Lactate. I don't think I have the vitals here. But her vitals, she's tachycardic. blood pressure's within a good range and she has a fever. And respiratory rate is like 30, kind of shallow, no wheezes. Yeah. Right. So, and now we'll get into that. So, things that maybe we could add on to our pneumonia workup list will be, you know, sputum culture could be considered here, as well as the Legionella and strep pneumonia urine tests. So when we, let me get this out of here, are looking at some of these other tests like sputum cultures, blood cultures, Legionella, pneumococcal, we're often just kind of reflexively adding them on, but most of us are working in this outpatient setting as well. You don't necessarily need those in the outpatient setting. Inpatient, if you're not thinking it's too severe, probably don't need them. But if we start to get inpatient and we're thinking, okay, this is pretty bad pneumonia, we're thinking sepsis, you do want to be doing the sputum cultures, the blood cultures, Legionella, pneumococcal. Mercenaires is typically for like really bad pneumonia if you're thinking you're going to go to ICU, and as well as for like hospital acquired pneumonia, more likely. But it's also a consideration if they have the Mercenaires positive. Okay, and, yeah. I will answer that. I will answer that question actually. Yeah. Okay. So, I hope this isn't cutting things off for the people at home, but it's cutting it off here, and I don't know how to get rid of it. Oops. More. And view floating window. I just click that hide window. Oh, that hid that window. QA pulling options. Oh, view. I could. Well, yeah, then we can't see it very big. Okay. Meeting. Okay. Sorry about the technical things, but we'll go back in here. I know. Okay. All right. So this is just on the left, you have the usual pathogens. So strep pneumonia is about 30 to 40% of your pneumonias. Haemophilus influenza, aspiration pneumonia, this Moraxella catarrhalis. And you have your atypicals. We often talk about those, like azithromycin is going to cover the atypicals. So those are your Legionella, mycoplasma, and your chlamydia. And then, of course, our viral pathogens, which there are many. And here on the right, you can see some of the different symptoms that might go along with some of the other types of pneumonia. You can have like ear pain, mycoplasma pneumonia. If you are having watery diarrhea, often you first think of like Legionella, but also mycoplasm. So I'm happy to share these slides after. They're very detailed, but I think it's a very sort of thorough review of, yeah. Okay. All right, do you want to talk about this? No, okay. Yeah, yeah. This is. Yeah. Go ahead. Yeah. Yeah, this is our like immunocompetent, like if you're seeing, there could be additional clues that could help you point to the type of pneumonia that you're dealing with in terms of their symptoms. This is a differential list. So things that it could be that it is not necessarily pneumonia. You can have atelectasis, PE, cancer, big one, sarcoidosis. There's eosinophilic pneumonia, interstitial fibrosis. So just some other differentials for us to be thinking of. So the patient was admitted for evaluation and management of sepsis and acute hypoxic respiratory failure, secondary to lower left lobe pneumonia. And I have actually not seen a Legionella case before, so finally got a positive hit here. And I really wish this was not here, but a public health nerd. So there are reportable diseases. And I don't know if you guys know this. So for Washington County, you're required to report all of the reportable diseases within 1 business day of the infection. I believe that we have infection control in the hospital doing this for us, but if you are also a public health nerd, it's kind of fun to like call them and report it, and they will tell you what else is going on. So I called and I reported the Legionella, and they said that there was an outbreak in the area associated with a cruise ship. So a bunch of people in the area had like gotten Legionella from this cruise ship, but our patient wasn't on that cruise, and person-to-person transmission just doesn't occur. So there's a phone number and they have the list of all the reportable diseases if you're not sure what they are. So there's a bunch of them. Yeah, it's with what? Oh, cool. Okay. So here's some of the results from the labs. Oh man, I really gotta get this off of here. If any, can I move it to the bottom? Oh, I have a mouse switch maybe. This thing? This one? Cool, thank you so much. Okay, so you can see the dates, which is just sort of helpful. So this is in September. So she's coming in. We have a little bit of a white count, hemoglobin's. Oh, sorry. Mm-hmm. Sorry. So he's saying Legionella is sometimes associated with hyponatremia. Sodium's low. Okay. All right. So white counts, low potassium, no AKI, we're doing okay. All right. So here's the chest X-ray. Just wanted to highlight how, you can sort of see a process occurring here. I really think the lateral view, especially with pneumonias, can be super helpful to kind of see more of what's going on. And you can also see a spinal stimulator on her here for her pain. And so this is her CTA in September. So you can see the consolidation there, pretty significant. And then I really wanted to highlight how this is a study, pneumonia recovery and discrepancies in the perspectives of the radiologist, the physician, and the patient. And so they took 119 patients and they looked at the radiographic imaging is what I want to highlight, and the clinical cure. So they looked at that at day 10, and at day 10, about 30% had resolution on radiographic imaging, and 93% had clinical cure of their pneumonia. And then at day 28, 68% had radiographic resolution of their pneumonia, and about 90 to 88.9% had a clinical cure. So this is to highlight how much our imaging lags behind the clinical picture of the patient. The imaging is just one piece of a patient, and clinically what's happening is so much more important than just the imaging. So really a whole patient's clinical course should be considered. We can't just put everything onto the images here. So risk factors for really severe pneumonia, this patient definitely had a few of them. So if they have emphysema, which our patient had, so decreased just functional baseline capacity of their lungs. If they have cardiac issues, congestive heart failure, this will also contribute to that. And then, renal insufficiencies, advanced age, always risk factor, and then impaired immunity. So this patient also had some impaired immunity with their immunosuppressant medications, their TNF alpha. So that was a recipe for pretty bad pneumonia in this patient. Other things, this is from Up to Date for Legionella pneumonia. So you're going to select either levofloxacin or azithromycin. And this is where I think we messed up. Treat for a minimum of 14 days and adjust it based on clinical response. And you also want to consider reducing the immunosuppressant medication, which we did. We told her not to get her next infusion. And this is just, we're always kind of tempted with lung issues to maybe, do we start steroids or not? It's not really well studied. And in this case, we did not start steroids for her pneumonia. So she had some improvement on the azithromycin, and we sent her home for a total of 14 days. And let's see. I also, with Legionella pneumonia, this is still from Up to Date. You'll see someone start to get better on the therapy in about 2 to 5 days, which is what we saw. We talked about the imaging lagging behind, but it's pretty severe. Up to 44% of patients with Legionella pneumonia require ICU admission. So this is a pretty intense pneumonia to get. A lot will also have fibrosis afterwards in the lungs. Okay, so we send her out. Right after she stops taking that azithro, she's back about 20 days later. So now she's back, but she has left lower lobe pneumonia that's worsening and hypercalcemia and an AKI. So we did not put her on a steroid. Yeah. Oh, why not? So it's a steroid can actually worsen someone's ability to fight disease. It's thought of as like an immunosuppressant, and it's really not well studied in Legionnaire's disease. So it was just thought that, okay, do we do the steroid in this case or not? You can have a lot of inflammation, and she has the risk factors for RA, which you're worried about her immune system going nuts. We had looked at her CRP and her ESR. They weren't excessively high. And so we were saying, we're just going to treat the bacterial pneumonia. Yeah, and not do the steroids. So it's not recommended to do steroids in this case. There's no evidence to support it. Okay, so now she's back, and she's back with hypercalcemia. So I have her labs here for us. Can you see them okay? Yeah. I'll let you guys look at them a little bit. And then I want to know, what are you thinking now? And what are we going to do? Yeah, so I'll show you on imaging, and she has a fever, cough, worsening fatigue, and sort of back to needing oxygen. She didn't need it for that time period, and when she stopped her antibiotic. now she needs it. So acute hypoxic respiratory failure. Yeah.
Prior already, she is still in the make
Yeah. Yeah.
Initial minutes in the visualization, but you didn't see anything.
Yeah. Right, right. Okay, so interesting. I just have the comparison labs from September and then to, you know, just October here. So 8.5 was her calcium then, and we're up to 14 corrected. And then, you know, hemoglobin's still the same. Interestingly, her ProCal was almost 12 in September and then totally fine on this admission. Okay. Her what? No, but that's great. So, oh, first I just wanted to chat about ProCal. So we are going to check that PTH, and I want to start with the interns, what do we do when we have a patient with hypercalcemia? But just talking about ProCal and how we look at it, I took a deep dive and I was like, okay, so procalcitonin, what is this thing? Oh, right. Typically it's made in the thyroid gland and it puts that calcium back into your bones. And when you have systemic inflammation, all of your cells release ProCal, not just those thyroid cells. And that's why you have that, that process going on, why you can correlate it with bacterial pneumonia. So the known triggers for ProCal release are typically bacterial toxins, including things like tumor necrosis factor, right? Which in this patient, okay, we have someone on a tumor necrosis factor inhibitor. How is that going to play with things? How is that going to affect our ProCal? So just wanted to point that out. And then also your ProCal can vary based off of the type of bacterial pneumonia that you have. So like mycoplasma and chlamydia bacterial pneumonia did not have any like detectable elevations in your ProCal. So you can have some variations. It might not always be high. Yeah. She did in September when she came in and not now. Yeah, I know. Okay. Here's her updated CT. So you talked about worsening pneumonia. It's just more, it's bigger, more full. I was just going to compare that. So, all right, differentials here. I liked the You said multiple myeloma, thinking cancers. Yes. Okay, great. Granulomatous diseases. Yeah. Anything else? Yep. Yeah. Yeah. Totally. 50-pack-year history, yeah. Mm-hmm. Yep.
Yeah, and then TB could also be maybe some other sort of another bacteria that was not treated for with the especially.
Yeah. Right, right. Okay, so how are you going to work up this hypercalcemia? Is the first year, anyone want to say first thing you order, hypercalcemia? It was already said. Yes, okay, great, PTH. What else do you want to order? Yep, PTH related protein and or peptide, and what else? Vitamin D, which ones? 125, okay. Any others? Great, okay. So you do want to do, can I move this? Great. When you have elevated calcium, you're going to look, is it PTH related or not? And that will sort of determine your tree. You want to look at the PTHRP. You want to get the 125. You can start there. You might also be getting the 25 vitamin D. You can consider these lytic bone diseases and then other causes of why someone could have this. So we'll come back to this diagram, but I just want to give you our lab results. Oh, and then for me, I'm always like, oh, vitamin D, like 125 is like, which one again? So I always think of 125 dihydroxy vitamin D. It's 3 numbers, so it's D3. That's how I remember it. 2 numbers, 25, it's D2. And calcitriol is D3 tri, and then diol is 2. So D3 is 2, or is the 125. Okay, great. So here's the results. If you've ever done this workup before, you know that PTHRP takes like a week and a half to come back. So here's what you get. PTH suppressed, 125 elevated a lot, 25 barely elevated. Interestingly, and she had a normal in 2019. That was what we had for her. And then I just wanted to show that her calcium persisted high while she was inpatient here. We treated her with some fluids, but persistently stayed high. The calcium, yeah, so it was 13 and we got it down to 10.7. PTH is suppressed. PTH is suppressed. Vitamin 125 is high, and 25 is mildly high. So what are you going to do next? Mm-hmm. Mm-hmm. Yeah. Mm-hmm. That's a really a great thought. That one. Yeah. Anything else you guys want to do with that? Like, where are you going to go from here? Well, we called endo. Just to be sure. Sorry, did someone else say something? No. What was it? We did, and I can go back to those images. It was the pneumonia is bigger. It's a lot. There's, and I'll get to that too. There's a 9mm nodule along the left fissure that is slightly enlarged from 2019 when it was done. 9mm. So ACE? No, like the trypsin thing? Or what are you thinking? Oh, I see. Okay. So we called endo and he was thinking this is milk alkali syndrome. And I didn't know what that was. So milk or calcium alkali syndrome. It's where you consume a lot of calcium and you're just taking in too much of it. So that's why it's called milk, like you're drinking a lot, but you can also, all these supplements. So that presents with hypercalcemia, a metabolic alkalosis, and an AKI. And our patient had an AKI, but they didn't have a high bicarb. They didn't have this alkalosis. And it's basically the process is down here for how the calcium causes you to basically have high bicarb when you're trying to get it out in the urine. So we didn't believe it, but we did go ahead and take a look at all of the over-the-counter supplements that she takes. So she brought them in, and then we were like, thank you so much. And then the nurse and pharmacy was like, you can't keep these here, and sent them home. We we're like, oh no, but we finally got a list. So D3, she's taking 125 micrograms every morning, and then she was taking the calcium 500 gummies. So I always struggle with this, and I have to look it up every single time in outpatient clinic, and I feel like it's like when I have the least amount of energy, but it is important to be doing this right. So I just went through the dosing. So for osteoporosis prevention, it's around 20 to 25 mcgs per day. For high dose therapy, this is if their serum 25 level is less than 12, then we're gonna give around 1,250 once weekly, which is less than the, or more than the, I think 125. You could, it's okay. No, this is for vitamin D3, all of it. The dosing is, you're basing it off of the vitamin D2 level. Does that make sense? So it's the vitamin D2 level that you're basing off your dosing for if you were going to dose D3.
That's the same as that.
I think I also have the vitamin D dosing for D2 at the back end of the study if we want to go over it, but this is specifically for vitamin D3 dosing. Like this patient was taking vitamin D3 at 125. So that's why I was like talking about it here, just, and what I'm trying to do is look at how much, is she truly taking a lot? Yeah, she kind of is. Like even for like low dose therapy or maintenance therapy, you're doing 15 to 50 mics daily. So kind of like she's kind of taking a lot on her own. This was just her own decision to start taking vitamin D3. So maybe. So again, we went back to endo with this information and they were like, I think she's just taking too much. I think it's not milk alkali syndrome. You're right. I think that she's just taking too much. For calcium supplementation, you can do you're supposed to get 500 to 4 grams in your diet every day. So she's kind of on par with that. Taking 500 is probably not doing anything. Yes, but she only said she took it like twice. So I was like, it's not enough. So, okay, maybe she's taking too much vitamin D3, maybe. But if we go back to our diagram and we're thinking, okay, the 125 is high. We're thinking maybe it's vitamin D, but not really sure. It's not showing it. Our next one is actually granulomatous diseases. So going down that pathway, looking at all the possible causes here. So we got bacterial, mycobacteria, Bartonella, Brucella, Coxiella, tularemia, and your endemic mycoses, fungal. So Canada, also some immune things, but we don't have those. Drugs, she's not on these. She doesn't have any tattoos. Lymphoma, possibility, and other autoimmune. So I mean, maybe sarcoidosis, but she doesn't really have a lot of the other things. She does have RA and Sjogren's, so that's on there. It's a possibility. So I wanted to talk about endemic fungi because I was also thinking histo. She's got birds, and I was like, I knew that like birds and bats for histo like ring in my ear. But location does matter, and I just included this image of how it looks, but if you take a deep dive, this is like textbook. You can get a consolidation with histoplasmosis. It doesn't have to have this type of appearance every single time. So, you know, I don't know how we're doing on time here. Okay, so then the map wise, we're actually much more likely to have a cryptococcus in our area than we are histo. So histo is kind of more like Midwest region. And then coccidio could, you know, down here, again, no recent travel. So ID was leaning a little more like cryptococcus for this patient. And then, but however, the history really fits for histo, which is chicken coops, barns, soil. She works a ton with soil on her farm. So if there's any bird or bat droppings in that, maybe could happen. Okay, so the tests then. So what are the tests that we ordered? So these fungi tests are the histoplasmosis, urine antigen and serum, 1,3-beta-D-glucan, aspergillus, mycoplasma pneumonia, cryptococcal mycobacterium, and then ID also did a send out for chlamydia. All of these were negative. Here's your first, that sputum culture from her readmission. Her sputum culture was growing Klebsiella. It was growing some yeast and some E. coli. And it was actually a resistant Klebsiella. So we were initially treating her with Unison. So we traded that up. And then, you know, she was worsening. She was not getting better. We were worried. And so I wanted to talk about bronchoscopy. Sometimes things get thrown out as kind of like these hearsay statements during rounds or in your interactions with people that might not necessarily be true. And so I do encourage you to like continue to research some of these statements and look into them. Because I, at one point, was told the yield for bronchoscopy is quite low. And this was during my pulm rotation. And I actually finally researched it for this case and have found it's actually can be quite therapeutic. So when are we going to do bronchoscopy? When you have just pneumonia that's not getting better and you're not sure why, that's a good indication. And I'll talk about the yield for that. If you have persistent atelectasis, maybe there's something in there blocking it, a lung mass biopsy, hemoptysis, any kind of airway obstruction, burn injuries, toxic inhalations, transplant evals, chest trauma, fistulas, all reasons to do bronchoscopy. And now that we have that here at this hospital, like take use of it. So this was what I saw for the diagnostic yield for these. I found 2 different studies here, and about in 968 cases, an underlying cause was identified in 28% of patients with unresolving pneumonia. In this case of 216 patients, pneumonia was confirmed in 46% of the patients. So I would say if you're really running up against a wall, there is some utility in getting the bronch. And then in our case, the bronch found a lot of really thick mucus secretions and plugs in that left lower lobe. They cleaned it out, and after cleaning it out, the patient woke up, felt so much better that she discharged home. She's getting followed up by poem this week here. This was the result so far of her her lower respiratory sputum bronch. And I think the aspergillus has come back negative. And then finally, we got her PTRP back. So her PTHRP is 4.1, and normal is 0 to 3.4. So I just included the fact that she has this 9-millimeter nodule going on. Her 125 being elevated with the PTHRP is not good news, most often associated with Hodgkin's lymphoma or non-Hodgkin's lymphoma. However, I did some more research. I was like, could this be a false elevation? Is there anything out there? So there are some non-malignant conditions that have been associated with elevated PTHRP levels, and this includes systemic lupus, which, you know, she doesn't have lupus, but she has RA. I don't know if that's reported. HIV, lymphedema of the chest or pleural cavities, or other benign tumors or kidney or neuroendocrine tumors. I read this case report of identified causes of PTHRP, 82% due to malignancy, okay, to solid organ malignancy, 8.7% due to blood malignancy, and only about 8.7% were due to like other causes, which they contributed 1.4% to CAP and other unknown. So odds are not in our patient's favor, unfortunately, that this is not cancer, but we still, we don't know yet. So that's the case that we had. Yes, I think levofloxacin, is that right? Yeah, so we're doing levofloxacin. How many days did we give her? 14 days, yeah. Yeah. So she has close follow-up, and I just hope we keep it close. I do think like some takeaways where I think I made a mistake by we're always pushing to like take care of our antibiotics, but I feel like we also have to take care of the unique people that come in, and in her case, I think we should have done a longer course for her. Initially when we discharged her, we just did the minimum. 14 days. The first time we did 14. Yeah. I think a closer follow-up, that like a follow-up visit right after she were to finish her antibiotics and to maybe try to catch that could have helped. Yeah, but there's a really great up-to-date article on like non-resolving pneumonia as well. That it's really long, but maybe worth reading at some point. Yeah, yeah. A contaminant. Yeah. Yeah, I think I could do some more digging with that too. In this case, it was just so interesting, especially with her ProCal not being elevated, like all the things. I was also curious, like, is there any impact of that ProCal and the hypercalcemia? Like, did she have the hypercalcemia? And then, but in terms of the sputum cultures, like the thought was that she had a secondary bacterial component going on after we treated her. Yeah, so we did broaden. And we had her on broad for a while until. Yeah. Yeah. Thanks. Yeah, I'm happy to share it with people. Yeah. Thanks. Thank you.